And okay, Robin, I'm going to ask you. Robin's got this bright sun behind her. They're doing construction over there at the hospital, so it's a little bit hard to see her face, but we'll make do with how we've got it. It's hard to block the sun. And in Boone, when you've got the sun, you don't want to block the sun. So
yeah.
Robin, it's good to see you. Thanks for making time to be with us. I'll just ask you to introduce yourself and talk a little bit about your roles in the community.
Here and see if that's better.
Oh, look. Yeah, that's great. Thank you.
Yeah. Oh, you're welcome. You're welcome. So thank you for having me. Just a little bit about myself. I am a registered nurse, have been a nurse since 1984 and came to the high country about 10 years ago to work here for Appalachian Regional Healthcare System as the Director of Care Management. And my background has been acute care nursing and then 23 years of post-acute care nursing in home health settings and done a variety of things, lots of education on different chronic diseases. And so in my role here at Watauga, I have staff at Watauga and staff at Cannon. We do see patients that come in that have experienced trauma in their lifetime or experienced trauma, and that's why they're here. And I know that, you know, through working with Denise and a lot of childhood trauma people experience, then we see them as adults, and there's lots of chronic disease that we're seeing and lots of emotional distress. I think about one person, we've had a couple of patients that have had serious physical and sexual abuse as a child. And so just being aware of their situation, you have to think about different caregivers, especially like one lady had severe trauma and she was coming in to have a baby. And so, you know, thinking about a female nurse versus a male nurse, those kinds of things. And then just doing some education with staff and, you know, just meeting them where they are. Sometimes these patients can be very difficult and they're, you know, they're scared and they're, you know, they feel out of control. And so just trying to meet them where they are. We have amazing staff. And so just making sure that nurses are aware of the trauma and then, you know, making sure that your tone and how you speak to a patient, trying to meet their needs. Sometimes, you know, there's drug seeking behaviors that we experience, and just making sure that the whole interdisciplinary team, including the physicians, are aware of the trauma. And for one patient that was probably one of the hardest patients we've had since I've been here, we would meet in the morning, every morning, so that everybody was on the same page, because we were giving mixed messages. And that was just, you know, when somebody already feels out of control, then they don't know who to trust. And then they, you know, use this person against that person. And so really it's important for the team to be aware and to us all be on the same page.
Robin, I appreciate you mentioning about reminding everybody about how trauma in childhood can carry over to health as an adult, because we could have talked about that first, but I think most of us on this call know about the original ACEs study in 1998. And that's actually where this adverse childhood experiences term came from. They were trying to figure out at the back end, adult depression, adult obesity, adults not responding to treatment. And when they went back and studied, you know, what they had in common as children, that's when they found this link to childhood trauma. I know you know what I'm talking about. This is more like for the audience, but for those of us who do ACEs work, we know that one of the really troubling parts of it, the childhood trauma, not just the trauma itself, but is how long that goes on into adulthood, where you do see elevated rates. And Nadine Burke-Harris in her TED Talk does such a good job with this, but where you see elevated rates of heart disease, cancer, diabetes, stroke, shorter life expectancies. And the thing I think really spoke to me that I teach to students and colleagues too is that inability to respond to treatment. And so it's the people that we see it repeatedly in the ER who are not following physician recommendation about changing diet or exercise or taking medication because their brains are engineered for survival. And
Right.
so they don't respond to those treatment things. So that was just a really good point to kind of summarize that for some people who may not know that as well as we can, that those traumatic events impact adult health for the rest of our lives.
Yeah. And I think that reminds me of a story of a gentleman that was coming frequently to our emergency department. He was, I think at the time we met him and started working with him, he was 23. And he obviously had an anxiety disorder. He was an insulin dependent diabetic. And so anytime that he would think his blood sugars were high, he would panic and he would call 911. And of course, they would bring him to the hospital. And so I just had one of my social workers just go and talk to him, just ask him what his story is, because I think we as healthcare professionals can be so judgmental. And, it's like, why do you keep coming in? Your blood sugar's not high. EMS was getting frustrated. If you called one more time and it's not an emergency, it's just all this stuff. Nobody had ever asked him what his story was. And so his story was that at 4 years old, his mother left he and his father and his brother. And before she left, she told him that she hated him and that she'd never wanted to see him again. So then she left. His brother got murdered when he was 17. His mother came back into their life when he was a teenager. He found her dead from an overdose. So he had this constant trauma. And so he's living with his father, who is verbally abusive. He has his own issues. They were living in a motel. They didn't have a refrigerator. He couldn't keep his insulin cold, so it would congeal. And so it was just sad. So we worked with them to get them into some housing, to get him some mental health help, counseling, got him cooked up with community care clinic. He was food insecure. We helped him with that and got him some care. And so he's able to hold down a job now. We still see him, but not frequent like that. And so if we hadn't asked, he would have just kept coming in.
Yeah.
And so, everybody has a story. And so just trying to meet them where they are and see how we can help. And there's some things that, there's some things we can't fix, but there's a lot of resources. We do have a rich community, and there are a lot of resources that we can help connect people with if they're willing to work and, put in the work and go to those appointments or whatever, and be willing to accept those resources.
And I want us to get into that in just a second, because I was surprised to hear about all the ways that y'all connect people. One more thought about what you said just then, that you hear frequently in trauma work about changing your perception from what's wrong with you to what's happened to you.
Yeah.
And how much that can open the therapeutic relationship up. And then the second thing that made me think of was, we come into it with this judgment about why are you, excessively, obsessively worrying about this sugar. And then you hear this long story and your thinking changes to, what a great job with all the trauma that you're dealing with, that you're trying to take care of yourself. So right. Just knowing the story can change your perception so much into how you think about people and interact with people. I know that was true for me when I first started learning all the trauma stuff that I did, because I've done this for generations, and watching the same people come back in the same ways over and over again, and just learning all this, it was this immediate shift in perceptions, and it just really changes the nature of your relationship.
Yeah. And we all have biases, but just being aware of what our biases are, and trying to meet people where they are, and just being open, because we were born into a different family, and we don't have any choice who we're born to. So just trying to work with people. And so,
Yeah. No, go ahead.
It's right. And you know, we've since I've been working here and been more aware of human and sex trafficking, you know, always trying to be aware that when we have people come through, that, you know, you just never know what situation that people are in. And so just being aware and knowing what resources and connections that you can connect people with. And you know, we do see some of that in our emergency room, but we also see it in our birthing center. And so just trying to be open and have staff be aware. So education to staff, and then knowing about what resources. And with the human and sex trafficking, you have to be real careful because there's typically always somebody with them, maybe an aunt or another person. And so a lot of times they won't talk. And so just, you know, a card or some kind of resource that, you know, if you need this, and having the language barrier as we always use an outside interpreter. We don't use family because, you know, we don't know if they're interpreting what we're saying actually. So that's just something that we have to be aware of in our area because of the seasonal workers that come through.
Yeah. And that was something that I think when I think of the hospital, I think of medical, you know, medical car accidents, emergency room, surgeries, and that sort of thing. And then if you don't realize it, if you are at risk for harm, self-harm, and you go into the emergency room, then there's mental health needs. They are present, but you don't walk into a surgery or a car accident or whatever it is and leave your trauma at the door. So not only can be very direct, like, you know, prevention of suicide, but people carry their trauma experiences, like you said, into their interactions with y'all. And so y'all are dealing with mental health issues probably just as often as physical ones.
Yeah. You know, we're always looking at ways to how can we help people be successful. Maybe they have a chronic disease, and so we're always trying to prevent readmission. So making sure that they get the information and the help that they need, and that their care transition to home or wherever is safe. We get them connected with a primary care physician, but a lot of times it's the trauma or the polypharmacy or the mental health problems that they have that maybe are untreated. Those are a lot of times are the reasons that it leads them back to the hospital. And, you know, we do have a pretty significant homeless population. And so, you know, working with them, you know, and some of them don't want to go to hospitality house, and there's reasons that they don't want to go to hospitality house. And so, you know, trying to work with people. I know one time that we had this girl come into the emergency room. It was in the winter time. She was 18 years old. She had been sleeping in the woods. I think she had been sexually abused by multiple family members as a child. And so I guess there were people sleeping in the woods. And so she panicked from her past trauma, came to the emergency room. She really didn't need to be here, but it was supposed to snow that weekend. I mean, like significant snow, but I think she had been kicked out of hospitality house for 30 days. She had nowhere to go. She didn't want to call her parents. So I went to Walmart and bought her a tent. I bought her a sleeping bag that was the lowest temperature possible. I think this was in February, so there wasn't a lot of, you know, coats, but I bought her a coat. I bought her sweaters. And I remember walking through Walmart crying because this girl was 18 years old. And, you know, I was thinking, what if this was my daughter? And so I got her a backpack because, you know, everybody has a backpack. And so then I was putting chocolate in there and, you know, those things. But, you know, it's like you just don't know what people have gone through. And so sometimes just that little bit of kindness can make a difference.
Yeah, I appreciate you pointing that out. We talk about you don't have to be certified, you don't have to be trained, just a relationship with a positive adult. And one thing I hope we come back around to is every time I talk to you, you tell me these stories, and I'm like, it's so far above and beyond. I think typically somebody would be like, well, here's some referrals of places you can go. Good luck to you. Yeah. But I continually hear over and over again how y'all go that extra mile to make sure that not just their medical needs are cared for, but their physical and emotional needs as well. So I'm hoping we'll get back into that in a minute. So, and so we're kind of naturally moving into resources and programs and supports and services, one of which is y'all definitely have this, whatever it takes kind of attitude. If there's a need here that needs to be met, then we'll find a way to do that. But can you talk about some of the more formal things that y'all do to take care of meeting people's needs?
Yes. So when I moved here from Asheville and was doing home health. And so came to this community and learned what a generous community that we have. And so our foundation, we have people in our community that donate money to the patient emergency fund of our foundation. And so we're able to buy medications. Sometimes people can't even afford their $3 copay for their Medicaid. I'm seeing more and more elderly people that can't afford their copays and are food insecure. So we're able to help with making sure they get their medicines, or if it's and making sure they have a sustainable plan. We get somebody that comes in, they're self-pay and they're new insulin dependent diabetic. I mean, I can spend $700 just like that on insulin and supplies. And so we work with the drug companies, and work at the application and that sort of thing. So we get them a sustainable plan and connect them with, Hunger and Health or whatever. We also are paying for, like if they need any kind of equipment when they're discharged. Sometimes we're paying for a month's worth of oxygen. We're paying for wheelchairs, for walkers, bedside commodes, whatever they need to help them be successful. Because, we all want to stay at home. And so there are lots of things that can be done for you to stay safe at home and have some resources, and then make referrals to home health or in-home care, making sure they have a primary care physician so that they have that ongoing care. So we do a lot of those connections. And then back in 2017, we started assessing for food insecurity. So food insecurity is a term that's used. So if in the last 12 months, your money ran out before you, and you needed more food. So basically it's two questions worded opposite. And so if you have run out of food or run out of money in the last 12 months, then you're considered food insecure. And so pre-COVID, we would give a box of, it's about a 20-pound box of non-perishable food items. And we tried to tailor it, with no added sugar, no added salt, that kind of thing. And then connect them with resources with Hunger and Health or whatever the food bank was in their county. And so, I've been working with Elizabeth Young at Hunger and Health for many years. And then we started collaborating with the Blue Cross Blue Shield Foundation was giving out grants for community-centered health. So we applied for one of those grants. It was an 18-month process to even do the application. We were accepted. I think we were one of 7 out of like 700 applications. So we got the grant, and so we collaborate with the nutrition department at ASU, and then also Yolanda Adams with the Watauga County Schools. And so through that program, we've started working with communities where there is high utilization of our emergency department, but there's also food insecurity. We've had forums with people from Bradford Park and different areas in our county, and identified that especially the Latinx population, they didn't grow up eating canned foods. And so we started our goal was always to get fresh fruits and vegetables, but And with this grant, we were able to start working with farmers. And so now Hunger and Health Coalition is one of the largest customers of the food hub, and they're using our local farmers to get fresh fruits and vegetables. And so we've increased the access for fresh fruits and vegetables for people that are food insecure. Now, when COVID hit, we weren't able to get those food boxes anymore. And that was probably a good thing because, processed food's not good for us. And so we had this idea of a food prescription. So we came up with a food prescription to give. And so when we identify somebody here in our hospital or any of the hospital owned physician practices, which is the majority of physician practices in Watauga County, then we give this food prescription and then connect them with Hunger and Health Coalition. If they're diabetic, then they can get nutrition counseling through the dietitian students at ASU. We've been able to make the snacks and the backpack program a little healthier with the Watauga County schools. And so we're continuing that work. And so post-COVID, we're going to start scheduling cookouts for people that want to come to Hunger and Health and hopefully connect with people and kind of see what their barriers are. We know food is one barrier, housing is another, transportation is another. And so how can we make this a healthier community? And so I'm very proud to work for a health system that's very engaged with the community and want us to do this work. And we are kind of blazing new trails because a lot of the big health systems, they don't have that same ability or focus. And so we're actually setting an example, and we'll be able to, let other people know how to replicate this in the future. So I'm super excited about that. And I know, as a nurse, I'm trying to bring a face of food insecurity to physicians. I've talked to lots of doctors and they had no clue what I was talking about. They had no clue that their patients were food insecure. And so I have lots of stories, but I'll just tell you one. We started doing it at Harmony. And so they had a 65-year-old woman come in for a checkup. And so the assistant asked these questions and the woman just burst into tears. She was one of their first ones that they had screened food insecure. And so the assistant was, oh gosh, I'm sorry, I didn't mean to upset you. And she said that her 90-year-old mother lives with her. And so she always makes sure her mother has food to eat, but there's days when she doesn't eat so her mother can. And so if we hadn't have started this, these people would continue to suffer. And so we're able to set them up with resources, but then the physicians are much more aware and they're like on board now. So when COVID hit and we couldn't get those food boxes, the doctors were giving money to the staff to go out and get stuff to give people when they came in. So it's really gotten our physicians and our medical team involved. And so, I'm excited to see what, this is going to do and how much healthier our community is going to be. And
yeah, it's so cool. What I remember, I wanted expressly for you to talk about that because when I came and talked to you years ago, and you said to me then, it's come to our attention that people, when they check out from here, are food insecure, and we want to give them a box of food. And I remember my brain kind of twisting in my head because that's just not what you think of as a traditional medical model of there's a sickness, we're going to give a prescription, we're going to send them home.
Right.
And so your willingness to think outside the box and to connect, now we know food insecurity is actually a form of trauma. And so you're not just addressing the need in the moment, but you're also doing prevention work, which not a lot of people want to get on board for. So I was so interested to come back now 2 or 3 years later and hear what you had done with that and how beneficial that must be to people who are going home to an empty house and an empty cabinet with, if there was food, it's probably rotted in the refrigerator by now. And what an advantage that gives them, compared to if they hadn't had that.
Yeah, yeah. And you think about, I mean, it's hard to put yourself in some of these situations because we've never experienced them. But, if you're having to worry about housing and you're having to worry about food, how can you worry about how to manage your diabetes or your heart failure? That's just not, I mean, it's Maslow's hierarchy of needs. And
Mhm.
if you don't have those basic needs, then you can't focus on the other. So
I remember reading somewhere, I can't remember if it's the health department report, some report, local report in the past year or so, that said the percentage of people in Watauga County that had to decide whether to pay electricity, rent, food, or medical bills.
yeah,
And, not having the resources to do all of those things. And so,
yeah,
yeah, when we talk about people not responding to treatment recommendations, finding out what the reasons are behind that.
yeah, yeah.
And so we talked some about resources and programs. For people who don't know about the social workers at the hospital, you and I have talked about them meeting with people to do discharge plans and referrals to places. I don't know that everybody on this call knows about that. You work also with, there's a behavioral, I don't even know the right term for it there, that where their counseling happens, and also a chaplain as well. Can you talk a little bit about your interactions with those programs?
Yes, yes. So when any patient is admitted to the hospital, after you get into your room, then the nurse comes in and does an assessment, and how you answer like some of the depression questions or different questions that will trigger a social work consult or a chaplain consult. And of course, the depression screening will trigger those. We are very fortunate to have a crisis team. And so a lot of times people come into the emergency room with suicidal ideation, or, they're wanting to detox off of alcohol or drugs. And so we have a licensed clinical social workers that are working in both of our emergency departments and can help get patients to the right place. If they're unsafe to themselves, then we have sitters. Sometimes they're involuntarily committed because there's a chance that they might take off, and they're not safe. And so we work closely with them, and a lot of times patients are placed from our emergency department. We're expanding our inpatient behavioral health unit at Cannon. We got some grant from the Dorothea Dix Hospital, the sale of that. And so we're expanding it from a 10-bed unit to a 37-bed unit. So
oh, wow. That's significant.
that'll be open in the next year. They've done a lot of renovations over there. So, and they'll actually be able to take people in. You won't have to go to an emergency room and then be transferred. They'll actually be able to triage people from there. And so that will help, because sometimes, especially geriatric patients that are having behavior problems, they're really hard to place because they have physical problems, not just emotional and psychiatric problems. So but my staff, Medicare requires us to do discharge planning on every patient admitted as an inpatient. And so, we're assessing people, and a lot of times people don't have needs, but sometimes, they might need help with home health, or, setting them up to go to a rehab facility for a short term. So we work with patients to get them what they need, and then we make sure they have follow-up appointments with their primary care physicians. So
that's a significant expansion from 10 to 37 beds.
mm-hmm.
For those of us who've done this a really long time in the state, I remember, oh gosh, now 12, 15 years ago, when we started closing psychiatric units and limiting the numbers of beds and closing residential units for youth. And so it feels like it's been this shrinking of services and supports for 10 or 15 years now. So the idea that somebody's getting to expand those is really exciting. So I look forward to hearing how that goes.
Yeah. Yeah.
So we've talked about trauma, we've talked about programs and resources. Let's talk a little bit about wellness. Before I start that, I just want to say, talking to you feels like talking to a social worker. So even though you have a nursing background, you do a really good job seeing the big picture and thinking about the whole person. And I'm sure that's something that they're starting to teach now in nursing, a more holistic, not just the medical, but the bigger picture as far as patients are concerned. Is that true?
I don't know.
Or is that just you?
I think it's just me. I've been around the block too many times. Well, and I do have to say, I am the daughter of my mother was abused as a child. And so having that insight and seeing what she has gone through, and, that trauma that happens to you as a child, it never goes away. So, my mom's 79 now. And so when she hears about any kind of sexual abuse, it sends her right back. And so I don't know if uh, I don't know. I'm just odd, I guess. But everybody thinks I'm a social worker. My best friend is a social worker. So I think doing home health and post acute and having the attitude, I'm just trying to make a difference. And so I just put myself out there and try to help. I don't like the word no. So there's always a way to figure something out. So
that must be why I feel an affinity towards you. I also do not like that word.
Yeah.
If there's a need, you just figure out how to meet it. So
That's right.
All right. Well, let's talk some about wellness, because having that spirit of there is, we're not going to take no, we're going to do whatever it takes. I used to call it relentless persistence. That is not always the most beneficial for someone's wellness. So talk to me a little bit about what you do for your staff to help them stay well, but I'd also like to hear about yours as well and how you balance that. We're going to make sure this gets taken care of with also taking care of yourself. So how do you emphasize that with your staff?
Well, I'm fortunate that we have a very active wellness program here at ARHS. And I think since COVID, especially, they have recognized how COVID has affected staff in general. And, when people were staying at home, we were, still here and coming in every day. And, you just were waiting for something terrible to happen, basically, and then it got crazy after the holidays. But so I try to, make sure that my staff know that I appreciate them. Some days when they're really busy, I'll bring in lunch or bring in breakfast. I always encourage them to take time off, especially in the summer. The older you get, the summer just flies by. And so in May, I start saying, okay, you guys got to start thinking about your summer, because a lot of them have kids that are, getting out of school and stuff. But I encourage them to take breaks. I encourage them to go and sit down for lunch. Don't sit at your desk and eat. And then, really try to encourage them to do fun things to fill their cup over the weekend or in the evenings. And so COVID was hard, I think, for all of us here, not just the staff that were taking care of COVID patients. And so I think that I finally took a vacation in May, and I totally detached. I didn't check my emails. My staff know they can call me 24/7, 365 days a year. And I told them I got to get out. I got to get away. And that helped. And then the other thing I've recently just tried to do is I've tried to at least, I'm not an avid reader, but I've tried to start reading at least 2 books a month this summer, just to get away somewhere. And so just allowing myself some time to sit and read, there's stuff, housework's always going to be there. So just trying to relax and refresh, and of course exercise always helps. So trying to walk and trying to eat healthy.
Yeah. One of the things is I've started asking lately is because we know the list of get 8 hours of sleep, eat right, exercise, those things. And then when we talk about why we may or may not do those things, and this is kind of personal, but can you share because I think what's missing for us is how we know when to do those things. Like, right. What is it? How do we recognize our own limits? When do we know when it's time to to stop for a minute and meet our own needs? So what are some of the ways that you know in yourself that you're starting to get to a place where you either need to rest or step back or do something to meet your own needs a little more targeted?
Yeah, I think that the majority of the time I'm very cheerful and optimistic. And so when I feel myself starting to get irritated with questions or, you already asked me that 3 times, though that's when I know. And with COVID, it was hard because I'm a very social person. I love to hug people. I have some close friends that we'll get together once a month at one of our houses and have dinner, and we couldn't do that. And so for an extrovert, it was very, very hard. And so I started to feel more and more, not depressed, but just kind of sad and just losing interest in things. And then in November, I got COVID, and then I was freaked out because it's like now I can't see anybody. Mm-hmm. And the holidays are coming and I want to see my kids. Like, I hadn't seen my children in 9 months. I hadn't hugged my grandkids. And so those are things that just irritability for me is probably the biggest sign. That's what my husband would say.
Yeah, that's some good insight. That's one of my triggers as well that I didn't know until long after I'd had kids. And I was talking to a counselor once, and after, how I lose it sometimes. And we realized that I know way before I lose it, that I'm going to lose it. And so doing something in that moment of recognizing the irritability. And I've heard a lot of people say irritability is a good sign for me that it's coming. So I'm going to stop and just stop for a second. Remind people, if you have a question or comment for Robin, you're welcome to put that in the chat. Mary McKinney had said that your caring spirit is incredible. And whatever comments that get put there, I'll copy and paste to you in an email so you can read them when you have time. Okay. Let's see, we've covered a lot of stuff. Anything? Oh, when you talked about behavioral health care, I forgot to prompt you again about the chaplain services. Can you talk a little bit about the support of the faith life that the hospital has?
Yes. Melanie Childers is our chaplain, and she does an incredible job to, bring in, if someone has local, a church that they're affiliated with. She actually started a program called, see if I can remember the name of it. I forgot the name of it. It's been so long. So sorry. But we have churches that are, and this was pre-COVID, of course, churches that where patients, people in their churches sign up to say, if I go to the hospital, I want Mary, who's the designated person at my church, to know that I'm in the hospital. And so then we would notify Mary that so-and-so is in the hospital. And then if they needed a ride, or if we felt like they needed maybe somebody to bring a meal, somebody just to call, these elderly people, they could go days without seeing or talking to people. And sometimes just a phone call means the world to them. So she was able to connect that. And we're just now starting to let people come in. We've expanded from 1 visitor to 2 now. And I saw a chaplain from Rumpel Church, Rumpel Baptist, I think.
Presbyterian.
Presbyterian. So he was here yesterday. I saw him. He had come to see somebody. So that's exciting that they're able to come back. But, she's able to connect people from different faiths, for last rites or things like that. And we do see a lot of emotional and moral distress at times, especially at end of life. And so just recognizing that and working with patients and families. And We work closely with the different hospices in our community, connecting them as well. So Melanie does a great job.
Yeah, I've met her. She's awesome. What I'm going back to the planning that y'all do with people and the checking in. And I told you this story, but I'll share it here. Our son, in the space of 8 weeks, his apartment burned to the ground, and then he got COVID, and then he had to have an emergency appendectomy. And so by the time he went in for this emergency appendectomy, he was at a pretty low point emotionally. And so he's 22, he's in college, but he lives in Raleigh. He called me that day and said, you need to come. It was a Sunday. And so I went and I stayed with him in the hospital. Anybody that knows me knows that I'm that kind of mom. Slept in the chair and all that for 48 hours, which, just an aside about hospital stuff, to me, it's like the comparison with dog years. Like a day in a hospital feels like a year on the outside. It's just so intense, and it just goes on forever. Yeah. So I was there 48 hours. It felt literally like a couple months. And so he's a guy, 22, doesn't really think about mortality and stuff. But on our way home from the hospital, he said, Mom, like, what do people do when they don't have a mom? Like, you came, you stayed with me, you made sure that I got my prescriptions filled because their pharmacy was in the hospital. You're taking me home. You're going to stay with me there. Like, what does somebody do that doesn't have that? And I said, I don't have a clue. And I thought about our hospital because you and I had already talked about this conversation and the discharge that y'all do and making sure people have rides and things like that. But just to say, the presence of social workers or people who are doing discharge planning and making sure your needs are met, and the success in recovering from that medical trauma or event has to make a really huge difference. When I think about him going home, not knowing how to get there, not having food in his house when they got there. I thought of you again too when I was putting food in his freezer, like that was empty because he's a college kid and they don't have food in their refrigerator. And so just the huge difference in the planning for needs beyond just the wound care or whatever, and the success of the recovery.
Yeah. And that reminded me of, with the food insecure people, because of the need, and there are elderly people that live out in the far areas of Watauga County, they've actually got somebody that can do food delivery now. And so, if the little old lady out in Sugar Grove needs food, then, they can deliver it. And so that has been, because of the grant and our ability to expand that program. So, because there are people like that.
Yeah. How long does that grant have to go? And do you think y'all will be able to sustain that after it's done?
That's the plan. Because of COVID, I think it's going to last 3 more years. And we are working to set up things like our foundation has supported the food that we've supplied here at the hospital and what we're getting from the food bank or from Hunger and Health. And then that includes the physician practices. So I think that will continue. I think that just being able to share those stories and let people know, and then hoping that, with the food banks and with the programs where, people are growing more food locally, hopefully the even simple gesture, where people in the community can donate and they'll keep those pantries full. Then, the goal is for us not to need that. I know that we will, but to not need it as much and help our community be healthier in the future. So, and it doesn't happen overnight. It'll be years in the making.
Yeah, I know I said it already, but those food boxes are not just taking care of the prevention of trauma in the moment, but also prevention of trauma long-term and increasing in health as well. So just really cool that y'all took that on as part of what you want to do. So again, if you have a comment or question for Robin, put it in the chat. Somebody asked about the bed expansion, and I said Cannon and Better Elk. So Robin, is there anything that I didn't think to ask you that you feel like you want to share about what y'all do or how you take care of needs? We've covered a lot.
I guess one thing that, you know, that makes us successful is that a lot of my staff have been working here a long time. You know, I've got one social worker that's been here 25 years, one that's been here 20, and one that's been here 18 years. So I think, you know, they're very engaged in the community. They went to ASU. But I do think that there is they all have a caring spirit. And so, you know, no matter if you work in the hospital or you know, you're just somebody in the community, just being open and being helpful however you can, and, you know, a kind word goes a long way.
Yeah, we talk about the number one factor to offset trauma is relationship with a positive, consistent, caring adult. And so that's when I was saying earlier, you don't have to be certified in something, don't have to have a degree, just positive interactions with people. And speaking of which, I'm assuming that you may not even know about this, that if somebody did want to volunteer to be a person that goes in and visits with people who don't have family coming by, is that still something that's possible to do?
In the near future. And thank you, Larry, for app Faith Health. Couldn't pull that word out of my brain. But yes, in the near future, that should expand. Now, you know, I do feel like that we do anticipate that there'll be an increase in COVID again in the fall with the flu season and stuff. But I'm hoping that you know, we'll be able to open it up to more people as more people are getting immunized. And, you know, I know our counties, I think it's close to over 50% now that people have been vaccinated. So I'm hoping in the near future, because it is important.
Yeah, I agree. One last question. So if someone has a loved one or a family member in the hospital that has needs that maybe aren't being, you know, maybe the patient didn't think to share, the loved one's concerned about them, what's the best next step for them to take? Do they get in touch with you or your office? Who do they call if they have a concern about a patient?
Yeah, they certainly can call me or call the social worker on the unit. You know, and if as a healthcare system, you know, we always have to respect people's privacy. And so if a patient's alert and oriented, I mean, a lot of times they can give us information. We can't always share information back if they don't have the passcode or if they're not their legal healthcare power of attorney. But I got a call today from a gentleman in the community whose neighbor had been discharged. I guess that person had been here and then went to Baptist and was discharged from Baptist, and the patient's not doing well. And so he just called to say, you know, what resources are there available? And so I was able to see that it was one of our physician practices that sees the patient. And so I just shot them and the doctor an email just to say, you know, FYI, this is going on with this person. So, you know, sometimes it's that, sometimes it's just, we can share what resources are available. Sometimes people, you know, as they age, it's harder and harder for them to be successful at home by themselves. And so, you know, home health can be a great benefit, but sometimes they need to go into long-term care. And so just knowing that information sometimes, because if you don't work in healthcare, you know, you may have never been exposed and know, you know, what requirements and what pays for what and what's out of pocket and that sort of thing. So
yeah, exactly. There was a question about, is there a way for people who either have a substance use disorder or misuse drugs and alcohol to go directly into rehab? So I know very little about this, about you can show up at a rehab and check yourself in voluntarily, but if someone's coming to your emergency room with that issue, do you know what the process is after they come?
Yeah, especially alcohol. Well, I mean, some drugs, but alcohol rehab, especially if they have significant abuse, it's not safe for them to detox at home. It can lead to a medical emergency. So we do have people that come here and want to get off alcohol, and so we work with them to get them into a alcohol facility. Sometimes they have to be admitted to get through if they have with serious withdrawal symptoms. And then once they get through that, then we can send them, but it's voluntary. So sometimes once they go through DTs, then, you know, and then it's like, well, no, I just want to go home. And so I think the hardest thing for people with drug and alcohol abuse is just getting the mindset to that they want to do it, because it's hard work. And so we certainly can help them get them to a facility, and you know, it's voluntary. So you know, a lot of times they'll need somebody to take them, and if they don't have somebody to take them, then we'll provide transportation as well. But so yes, we can help people with that, and it is a significant problem that we see that does interfere with people getting well, and a lot of it is the result of trauma from their childhood, is what we see.
So people can go directly into rehab, but they also can come through the emergency room as well, and y'all can help with that process. Good to know. All right, Robin. Well, we have kept you for almost an hour. I appreciate you so much being with us. It's always such a pleasure to talk to you and see your spirit and energy and enthusiasm for this work. So thanks for spending time with us today.
You're welcome.
Everybody, if you have something that you'd like to say to Robin, you're welcome to type it in the chat, and I'll send it on to her by way of an email. If not, I'll see most of y'all next Wednesday, maybe not Robin, but Robin, I hope you have a good rest of the summer, and thank you again for being with us.
All right. Thank you. Y'all take care.
All right. Have a good day.
All right. Bye.
Bye.